Let's work through a confusing topic and make it simple. How do we localize a lesion that is causing weakness of the eyelid? All right, so we can do this by asking two simple questions. Question one, is there a problem that the eyelid can't shut, or is it that it can't open? And this is important because if the eyelid can't shut, then you're done. The problem is going to be cranial nerve 7 or the facial nerve. That's because this is the nerve that innervates the muscles for eyelid closure. The most common cause of this is going to be Bell's palsy. And you can confirm on your exam that the problem is the facial nerve because the patient is going to also have lip droop on the same side. On the other hand, if your problem is that the eyelid can't open, this eyelid is going to look different. It's going to look droopy, and the medical term for the droopy eyelid is ptosis. And there's two potential causes for this that we have to work through. So we need to ask our second and final question, which is, what does the pupil look like? Is it constricted, so miosis, or is it not constricted, meaning it's normal or dilated, aka mydriasis? If the pupil is constricted, miosis, that means that our lesion has to have disrupted the sympathetic input to the eye. Remember, sympathetic makes your eyes wide open and makes your pupils dilate to prepare you for fight and flight. So when a lesion disrupts this sympathetic input to the face, we end up with ptosis, miosis, and also inability to sweat on that side of the face. That's called anhidrosis, and that's because that's also sympathetic innervation. So there's actually a name for this condition, which is called Horner syndrome. So finally, there's only one thing left, and that's if you have ptosis, but your pupil is not constricted, meaning it's either normal or dilated. And if that's the case, then your diagnosis is a cranial nerve 3 lesion. Cranial nerve 3 is called oculomotor. It's not only responsible for eyelid opening, but it's also important for movement of the eyeball and having a normal gaze. So a patient with a cranial nerve 3 lesion is going to have both ptosis and paralysis of some of their extraocular muscles. So this is going to cause a gaze problem in a way that the affected eye is going to look down and out. That's the classic description here. So you're going to get ptosis and a down and out eye. Now, interestingly, cranial nerve 3 also supplies parasympathetics to the eye for pupillary constriction, but these fibers are bundled separately. So they may or may not get damaged depending on the cause of your lesion. If they also get damaged, then the pupil will be dilated, aka mydriasis. If they don't get damaged, then the pupil will be normal. So to summarize, if the problem is eyelid can't close, then the most likely cause is cranial nerve 7 lesion. If the problem is eyelid can't open, then we have droopy eyelid, aka ptosis, and in that case, then we have to look at the affected eye's pupil. If the pupil is constricted, then this is most likely Horner syndrome. If the pupil is normal or dilated, then the problem is most likely cranial nerve 3 lesion.